I've just started the recording of this open meeting in compliance with CMS. For the record, prior to doing so, I announced that Palmetto GBA would make an audio recording of the open meeting and consented on behalf of Palmetto GBA. Again, I'd like to welcome everyone to our open meeting this afternoon. There are a couple of things before we get started with our presentations. Number one, Palmetto will not be able to answer any specific questions today on any of our proposed policies. The second thing that I'd like to remind everyone is that we will have some time for comments. However, we ask if you would like to make a formal comment on any of our proposed policies, we encourage those to be done in writing. Those written comments can be submitted to either a.policy@palmettogba.com or b.policy@palmettogba.com. Again, we encourage those to be in writing. That's the preferred method. It's a very important part of the LCD process, and if we're able to get those comments in writing, that will allow us to adequately address each of those comments in the response to comments articles that are associated with each proposed policy. So with all that being said, we're ready to start with the presentations. Mr. Kong, you are up first. Now, all three of the scheduled presentations today are addressing the micro-invasive glaucoma surgery policy. So again, Mr. Kong, I'll give you the floor.
Well, first, I'd like to thank the Palmetto medical directors, CAC members, and staff for the opportunity to present today. I certainly appreciate the opportunity to not only represent NeuroMedical, but also the ophthalmology community and ultimately the patients we serve who benefit the most from the technologies and procedures that we'll be discussing today. My name is Raymond Kong. I serve as the Chief Commercial Officer for NeuroMedical. NeuroMedical is a glaucoma surgical device company based in Southern California, and one of our flagship products is the Cahook Dual Blade. So in the spirit of full disclosure, I am employed by and am representing a company whose products are used in the procedures being discussed. Earlier today in the Jurisdiction M open meeting, Dr. Okeke touched broadly on the challenges that the proposed LCD will create, and also spoke broadly on the need to continue to maintain options for all patients. My presentation and comments will focus solely on the goniotomy procedure, one of the procedures in the proposed LCD, and specifically excisional goniotomy with the Cahook Dual Blade. Before getting into the key points, it's important to share with you a quick overview of the product that I will be referencing and the clinical data being presented, the KDB. We've seen significant advances in techniques and technologies in the past 10 years in the ophthalmology space, and KDB certainly is one of those. This product is designed to perform a complete excision of the diseased trabecular meshwork, providing access from the anterior chamber to the canal of Schlemm and the distal collector channels. This is an important distinction because it is unlike goniotomies using an NVR blade or other unsophisticated instruments like bent needles, which were used in some of the studies referenced in your proposed LCD. The studies and results referenced in my presentation will all be consistent with true excisional goniotomy performed to remove the trabecular meshwork in adult patients. To begin with my first point, the draft LCD cited incomplete evidence for goniotomy, which in our opinion is neither experimental nor investigational. Goniotomy has been performed to treat glaucoma patients for over 80 years, and the procedure's safety and efficacy has been exhaustively documented as evidenced by over 94 peer-reviewed publications on excisional goniotomy alone, including a level 1 randomized clinical trial, which we'll touch on in a moment. The draft LCD cites only a sliver of the clinical evidence related to goniotomy that is currently available. The citations includes a listing of multiple studies with different goniotomy procedures or devices. This listing, in our opinion, shows the commingling of different procedures, different devices, as well as the age of the references, which certainly impacted the conclusions drawn. The body of evidence continues to grow even as we speak today. In 2020, we did a similar presentation to Palmetto, and at that time providing a list of 48 peer-reviewed publications. Here we are in 2023, and that listing has now grown to over 94. This data, by the way, was shared with Palmetto before in 2020, as mentioned. And so we continue to be concerned as to why these are not being referenced in the current proposed LCD. Let me draw the audience's attention to a current LCD, or I'm sorry, a current RCT. The LCD cites a lack of RCT data. And I would like to draw the attention to the existence of a prospective multi-center randomized controlled trial comparing goniotomy with the KDB and iStent implantation at the time of cataract surgery in mild to moderate glaucoma. I would like to emphasize here that the comparator in this study, trabecular meshwork stent, is covered by Palmetto in the proposed LCD. Results of this level 1 study were published in the Journal of Cataract and Refractive Surgery, one of the most prestigious journals in ophthalmology. Study included 82 open-angle glaucoma eyes in each arm, or 164 in total. And the procedures were performed across 9 clinical practices. The study's success definition was intraocular pressure reduction greater than or equal to 20%, or medication reduction greater than or equal to 1. You can see the results from the study in this slide. The investigators found that at 12 months, 93.7% of eyes in the goniotomy with KDB arm met the success criteria versus only 83% in the iStent arm. And this difference was statistically significant. There are also, as mentioned earlier, multiple peer-reviewed retrospective publications confirming this conclusion in real-world setting. My final point before moving on is that while we're being challenged for the need or on the need for RCT data for an 80-year-old procedure, we are not aware of an existing RCT data for the iStent Infinite, which is being proposed by the MAC for coverage. We're also only aware of one RCT for the Zen gel stent, which is also being proposed for coverage. To be clear, we are not challenging the decision for coverage by the MAC. We're only asking that the MAC be consistent and evaluate goniotomy using the same standards. These next slides are a listing of all available data on excisional goniotomy with the Cahook dual blade, and which I previously noted there to be over 94. This listing has been provided to Palmetto, and we will follow up with individual PDF copies of each. I urge the medical directors to review some of the most updated data prior to drawing conclusions on the safety and efficacy of this procedure. Now moving to my next point. Goniotomy is a well-accepted procedure among ophthalmic surgeons in treating adult patients. What you are looking at here is an industry report conducted by MarketScope, a well-recognized market research group in ophthalmology. What you can see is that non-implant procedures such as goniotomy and canaloplasty continue to gain in popularity, providing significant benefits to more patients. And I would argue that this is now standard of care. I believe there was an error in the LCD mistakenly citing a decrease in goniotomy procedures when in fact what we've shown and Dr. Akeke showed this morning was a decrease in trabeculectomy procedures, and that was incorrectly referenced, citing ab-internal trabeculotomy, a term that is often interchanged with goniotomy. Looking at this report, you can see in Q1 2023, Total MIGS procedures were split almost evenly, 55% to 45%, between implant-based MIGS and non-implant-based MIGS, which include goniotomy, canaloplasty, ECP, and others. I would argue that an investigational procedure would not have this level of adoption from well-respected surgeons who have taken an oath to do what is in the best interest of their patients. In addition to this real-world evidence, at a society level, goniotomy has also received broad-based support, which is my fourth point. The World Glaucoma Association's 11th Consensus Report on Glaucoma Surgery recognizes goniotomy with a KDB as an acceptable procedure and states KDB can be used as a standalone or combined with cataract surgery in early, moderate, or severe open or closed angle glaucoma to reduce IOP, hypotensive medication burden, or both. You can also see that goniotomy has broad acceptance by the American Academy of Ophthalmology. And finally, I'd also like to point out that in the Palmetto multi-jurisdictional CAC meeting convened in January of this year and referenced in the LCD, the members were very clear about the need not only for goniotomy, but for multiple options to be able to treat this terrible disease. And you can see some of those comments here. In summary, goniotomy should be included as a covered procedure for micro-invasive glaucoma surgery in the proposed LCD. We believe that goniotomy is neither experimental nor investigational, as demonstrated by the broad acceptance and numerous publications. There are over 94 clinical peer-reviewed publications, including a level 1 randomized clinical trial data demonstrating the safety and efficacy. Goniotomy is in accordance with accepted standards of medical practice and supported by major ophthalmic societies. And my final point, is related to financial considerations. And while we realize that this is not a primary focus, there are financial implications of a non-coverage decision by the MAC. A non-coverage decision for goniotomy and canaloplasty would force surgeons to substitute trabecular meshwork stent implantations for these procedures, which requires leaving a foreign body in the eye. So while the procedures may go away, the patients will not, and neither will the associated risk of implant-based MIGS. These substitute trabecular meshwork stent procedures have a markedly higher facility fee in an ambulatory surgery center setting where a vast majority of ophthalmic procedures are performed. By forcing care in this direction, a non-coverage decision would increase Medicare costs and, more importantly, increase the financial burden borne by beneficiaries in the form of copays. And I think Dr. Okeke stated again this morning very nicely the impact this would have in our underrepresented minority communities based on the prevalence of the disease in that population. I'd like to thank you for allowing me the time to present today, and I look forward to working with the MAC to reach a good resolution on this issue. Thank you.
Thank you, Mr. Kong. I appreciate that presentation. We'll keep moving along here for right now. Like I said, again, we'll have an opportunity at the end for comments, but I want to make sure everybody has adequate time to present. And so we will move to our next presenter, which is Dr. Karen Allison.
Good afternoon, everyone. My name is Dr. Karen Allison, and I'm a glaucoma specialist at the University of Rochester. I want to thank the conference organizers for the opportunity to present to you on the behalf of American Academy of Ophthalmology, the American Glaucoma Society on this important topic. As I said, my name is Dr. Karen Allison. I'm an ophthalmologist at the University of Rochester, a glaucoma specialist, and I thank you for the opportunity to speak today. I have no financial conflicts. Next slide, please. Okay, so today, glaucoma patients require continual and often escalating therapy for diagnosis through the end of their lives. Diagnosis of glaucoma from the beginning to the end of their lives. This is often a 15-year years or more, and in some cases, decades. Eye drops are often used as a first-line therapy, but many patients have very great difficulty using them. Using multiple drops markedly decreases adherence. For each individual patient, a target intraocular pressure below which progression of vision loss is not expected defines his or her goals for therapy. Refractory glaucoma refers to the intraocular pressure remaining above target despite the use of multiple classes of medication or fewer medications when tolerability or effectiveness limits the use of certain drug classes. Note that this definition does not include an arbitrary intraocular pressure cutoff, as many patients progress at an IOP of less than 21. For each patient who are progressing or are likely to progress at their current intraocular pressure, a careful, tailored surgical treatment option is often necessary in order to save these patients' vision. A brief summary of the surgical approaches being discussed today will help frame the discussion. A brief discussion, a review of the surgical approaches being discussed today will help frame the discussion. Goniotomy, as Mr. Raymond Kong explained before, refers to the incision, excision, or cleavage of the trabecular meshwork which overlies Schlemm's canal, the most proximal structure in the angle, the eye's natural outflow pathway. Techniques in this class include what was previously called an ab interna or other devices, and often an ab interna trabeculectomy with a trabectome or ab interna trabeculotomy using a gonioscopic assisted transilluminated trabeculotomy, or other devices and other techniques. Canaloplasty refers to a direct dilation of Schlemm's canal via cannulation or injection of an ophthalmic viscoelastic surgical device in a technique known as ab interna canaloplasty. The listed devices are among those used in this way. It feels appropriate at this moment to thank Palmetto for their coverage of trabecular bypass stents, which also addresses the anatomical point of outflow resistance in the drainage angle. Next slide, please. Give a mention of cytophotocoagulation or application of laser surgery to the ciliary body in the language of the draft determination, as well as CPT code for iridoplasty, which is application of energy to the peripheral iris. Those definitions are also relevant. As you know, and as others may discuss later, goniotomy has been the mainstay of management of glaucoma in young patients in whom high pressure often results from outflow resistance at the angle since the 1960s and 70s. Goniotomy is also necessary treatment for adults with glaucoma. Subconjunctival bleb formation and external filtering surgeries such as trabeculectomy, tube shunt implantation, and Zen gel stent insertion are effective for dramatic intraocular pressure lowering, but come with morbidity and long-term risk of infections and other complications. Patients with glaucoma refractory to medical management who require more modest intraocular pressure reduction need safer options, among which angle surgeries like goniotomy and canaloplasty have become standard of care. Moreover, many patients are poor candidates for filtering surgery and for the trabecular bypass stents currently covered. Surgically, goniotomy does not require dissection of the conjunctiva, which may be damaged or scarred from chronic topical medications, systemic disease, or prior surgery. Lastly, angle surgery is often performed at the time of cataract removal, which on its own provides inadequate intraocular pressure reduction in the majority of glaucoma patients, and may even cause a transient increased intraocular pressure and which also lowers the success rate of simultaneously performed external filtering procedures. Next slide, please. We will highlight high-quality evidence underpinning the use of goniotomy in adults as standard of care. Mr. Kong nicely reviewed this first publication, so I will be brief. A prospective randomized clinical trial comparing cataract removal by phacoemulsification plus goniotomy to phaco with trabecular bypass stenting was published in August of 2020. More phaco goniotomy eyes than phaco iStent eyes met the clinical significant primary outcomes of greater than 20% intraocular pressure reduction or reduction of medication burden by greater than or equal to one drug at 12 months. This result was statistically significant. Next slide, please. Furthermore, you can see that this trend held at all postoperative time periods, demonstrating that goniotomy combined with cataract surgery is at least as effective as trabecular bypass stenting. Next slide, please. The literature supporting goniotomy in adults with glaucoma stretches back to the early 1990s, and we will briefly present results from a review and meta-analysis of outcomes of goniotomy or ab interna trabeculotomy published between 2008 to 2014. From this first forest plot, you can appreciate that the weighted mean difference on the reduction in intraocular pressure between baseline and final measurements was significant for both standalone and combined procedures. Next slide, please. Next slide, please. Canaloplasty has also been extensively studied in adults, and here we briefly touch on 12 months results of a study of ab interna canaloplasty or ab interna canaloplasty combined with phacoemulsification. Here, the blue bars represent preoperative eye pressure and orange bars eye pressure 12 months after surgery. The asterisk indicate that this change was statistically significant for all eyes, both those undergoing standalone ab interna canaloplasty and those undergoing combined surgery. Lastly, psychophotocoagulation or application of laser surgery to the ciliary body to reduce aqueous production is a necessary tool in our armamentarium to treat glaucoma. We were puzzled by its inclusion in the draft LCD because this approach has been saving vision since the 1930s, and its safety and applicability only improved with the introduction of endoscopic cytophotocoagulation and micropulse delivery. While it is used judiciously, typically as a treatment of last resort for eyes that are poor candidates for inclusion, incisional surgery, or have limited visual potential, it is an effective and important piece of our standard of care for glaucoma. So in summary, patients with glaucoma, which disproportionately affect Blacks and Hispanic persons, need access to a range of surgical procedures reflecting their individual anatomy and disease feature. Many patients, even when treatment with medication is inadequate, the glaucoma is not yet severe enough to merit more morbid filtering procedures. These procedures become very helpful. For these patients, minimally invasive glaucoma surgery, like the angle-based procedures discussed today, preserve quality of life and reduce total cost to the healthcare system. With the increased number of patients that have glaucoma, that are in the have poor access to care, it's important that we have a wide range of procedures that we can offer to these patients. So for these patients, we urge you to ensure that Medicare beneficiaries with glaucoma continue to have meaningful access to these transformative procedures by providing coverage for minimal invasive glaucoma surgeries, including goniotomy, canaloplasty, and cytophotocoagulation. In fact, what I recommend is we have even more increased access to these procedures, because in these are life-saving procedures that will help decrease the rate of blindness from this devastating disease. Thank you very much for your time and attention.
Thank you, Dr. Allison, for your presentation. Next up, we have Dr. Yadgorov.
Thank you, everybody, for allowing me to present and take 15 minutes of your time today. My name is Arkady Yadgorov. I'm a glaucoma specialist, a very high-volume glaucoma specialist here in Atlanta, Georgia. I'm in the trenches. Glaucoma is a very difficult diagnosis to deal with and to treat. And I'm not here on behalf of any specific company. I am a consultant to various ophthalmic industries, many of which have MIGS devices. But I'm really just trying to convey what it's like to treat glaucoma, and why it's so important that we still have these tools at our availability. And I was also a clinical investigator in one of the trials that used the MIGS device, which we'll very shortly discuss. So in Atlanta, Georgia, I'm a referral-based center, and in essence, glaucoma comes in all types of shapes and sizes, mild, moderate to severe in terms of severity, but also many types of subtypes of glaucoma, primary, secondary, combined mechanisms, and anything in between. And the reason that's important to understand is that treating glaucoma is very much an art. It's not a kind of one fit for all. It's not that every single patient is going to be just, a stent or nothing, not a stent. They really come in various types of degrees and various type of unique presentations. And especially so in those with in the African American representation, those patients typically have a little bit of a different type of disease burden that can be quite hard to treat. And so when patients come to me, right, and they need, let's say, cataracts, a lot of times they have glaucoma just there that they were not aware of, and they don't really have insight into. And so as a surgeon now, I have an opportunity really to preserve that patient's vision from glaucoma by surgically treating their glaucoma. And I really want to delve into why surgically treat glaucoma, because if you look at the LCD and a lot of the kind of policies that's been out for decades, it's all about medication. If you think about it, well, you got to try the medication first. Well, now there's enough very powerful data, and here's one out of 2020 by Newman Casey, and there's a reference at the end of the presentation that shows that glaucoma's progression is no longer a problem with pressure. It's a problem with medication non-adherence. In other words, the medications that we have do work, but a substantial majority of patients simply cannot either take their medication, to not access their medications, or forget to use their medications. It's a lot more of a serious disease, a problem than I think many doctors and many peers realize. If you look at all the major papers that show intervention versus eye drops, despite similar IOPs, patients on the medication groups get worse more. And so this window of opportunity as a surgeon now is, what can I do long-term for that patient to stabilize their glaucoma and not have to rely on every single day of an eye drop for the rest of their life? And I think if you put yourselves in the shoes of the patients, and if I were coming to you and telling you, during your cataract surgery, I can do a procedure that may take you off your medications safely, or you need to buy this medication every single month for the rest of your life, and deal with the intolerances and the discomfort, I think it's a no-brainer. Some of my happiest patients are those in which I was able to control their glaucoma off medicines. Okay, so just understand that there's a reason that MIGS utilization has increased. There's a reason why this is such a big deal for glaucoma doctors. It's because we see people get worse on medications. And so we're there to finally start, using our doctoral skills to intervene on behalf of the patient and not kind of put the burden on the patient. And you know, majority of you agree that that makes sense. Let's do MIGS. And I'm sure some of you will go, well, stents are good enough, aren't they? You know, we're covering stents on the LCD. Why do we need this other stuff? And so we've already had very good presentations earlier, but again, just to go through the angle of me, a high volume glaucoma surgeon, I'm in Atlanta, Georgia. There's a lot of disease here, a lot of patients here. And since 2018, for example, I've been using the Omni device, which creates a trabeculotomy and a canaloplasty since 2018 with hundreds of cases every year. And 50% of them, of those, you know, 500 cases a year are with Omni. Now think of that. Why would I have that kind of a utilization, or why is the MIGS utilization increasing? And it's quite simply that it works. Surgeons won't use a device that has a high failure rate in their hands, right? This is something that glaucoma is a gift that keeps on giving. It's a chronic disease, and having a procedure that we can see the results in our clinics and see that safety, that's the reason it keeps going. Any procedures like trabeculectomies that you see a decrease in utilization, there's a reason for that, high risks. And so I just need you guys to understand that, that we're coming from a good place, which is we want to help the patient, and we've seen this work in our clinics. That's why the utilization has increased. And then the other huge part of this, and I really want to make sure to emphasize this in the square, is many patients are not good candidates for trabecular stents. For example, advanced stage glaucomas, right? FDA label for stents is only mild to moderate. And I have, you know, I'm actually publishing a manuscript on 70 patients that have advanced stage, and it works quite well. And there's already papers out by Grover, and I think I've referenced it later, where it shows that these procedures can work in mild, moderate, or severe. And so you're able to use a versatile tool that stents don't necessarily allow you to do. The other big improvement that these procedures like trabeculotomy and canaloplasty provide are in secondary glaucomas or in hyperpigmented meshworks. Think of the trabecular meshwork as the sponge, and the more pigment that's in it, the harder it is for fluid to get out. Now, you could put a snorkel in that sponge, which is a stent, but if that stent gets clogged, then there goes your bypass. As opposed to a goniotomy or a trabeculotomy, you're now having a broad excision of that plugged sponge. You're now having more precise or more predictable IOP responses. Combined mechanism glaucoma is very similar in terms of the trabecular meshwork being diseased more so than an open angle, and therefore being able to open that up. African Americans in particular have very pro-inflammatory irises, and they have thicker irises. They're more likely to scar a stent, for example. You know, I've seen stents that you see these large synechia or scarring of the iris, and that one stent and it scars, then the benefit's over. As opposed to, for example, the Omni or the excisional goniotomy, creating a wider treatment area, allowing a less likelihood of scarring that entire treatment area. And lastly, endothelial corneal dystrophy. There are many patients who simply, it would be a disservice to put a stent in their eyes because it's going to cause comorbidity to the cornea. And removing the goniotomy or trabeculotomy, you know, that's really the only safe option in those patients. So let's delve into trabeculotomy a little bit more and goniotomy. Really, it's holistically looking at it from 30,000 feet above. All we're really doing in these various ways, either trabeculotomy or goniotomy or ab interna trabeculectomy, this code 65820, it's simply telling us we're removing the trabecular meshwork in one fashion or the other to improve outflow. We're removing the site of resistance. And both of these procedures, which really do very similar things, have been around forever. They have a long track record. We're not doing anything that's dangerous to the patient. And, you know, yes, it's been, you know, in the LCD, it's mentions, well, with pediatrics, it works. We should just use it in pediatrics. But adults, I mean, have fantastic responses. And so what I mean by that is this is not something new. This is not a new kid on the block. This is not something that's been used for the past 3 years. The trabectome, which has been out since 2004, that's almost 20 years now of something that we've been able to use to create a goniotomy or trabeculotomy. And I think Dr. Allison mentioned the meta-analysis. I mean, you want data, you can't get any better than a meta-analysis in terms of data. And in 2017, by Kaplowitz, there's a meta-analysis that included multiple prospective studies, included over 5,000 patients with an 85% success rate at 2 years with this procedure. That's a high success rate. And if you just look at, baseline results with cataracts, this is much higher. The dual blade, I don't have to talk about it. Mr. Raymond Kong did a great job. There's an RCT for it. So there's really nothing at all here to talk about. It's a proven with evidence. And lastly, the Omni surgical system with the Gemini study, I'm sure that's been submitted to you guys. That is a prospective study, not retrospective, prospective, multi-center, washed out pressures. I mean, this is as high level of an evidence paper as you can get, with over 120 patients, with yielded an 84% success rate. In essence, doctors, excising the trabecular meshwork to treat glaucoma is not investigational. And that's really why I'm here talking to you, because I use it all the time and I have great results and the data shows for it. And so it's a little bit of a shock to a lot of us surgeons where, we're being threatened of not having that tool anymore to operate with. And so we're really here to try to convey to you that this is not investigational. This is something that works. I just want to pivot into MIGS comparisons and understand that you don't necessarily need an RCT to generate good data. For example, we have multiple prospective comparative data studies. For example, the ones here, like the Horizon, iStent, Compass, that very predictably tell you what cataract surgery does in a control group setting in 1 to 2 years. And you can see here about 5 to 6 millimeters of mercury pressure reduction, 1 to 2 years. And so the iStent inject showed, a treatment effect or a beneficial effect higher than that. Hydra showed about 8 millimeters, which is higher than the control. The Omni, which was the Gemini study, didn't have a control group. But otherwise, it's a prospective multi-center and washed out. So in every essence, it's this exact same type of representation and had 8 millimeters of pressure reduction. And that just shows you, and you can just look at it and go, well, yeah, that definitely works better than what we predict with cataract surgery. And so I think the level of evidence is there, and it's prospective, and it's rigorous, and it's published, and I think it needs to be reviewed. I'm a big proponent of the Omni surgical system in particular. I use it for a majority of my patients because it does both a trabeculotomy and a canaloplasty. And having that canaloplasty addition also helps with improving outflow channels and dilation of the outflow channels. And the data is quite powerful. If you look at the Gemini paper, you see really good data. And I think that's because of that 2-part procedure. I don't bill out for both parts. I billed as a trabeculotomy, but being able to use the canaloplasty with the device really improves, to me, safety and efficacy. Lastly, I just want to wrap up with standalone glaucoma interventions. These are patients who do not have a cataract and need better glaucoma control. I want you to look on the right. And these are the list of complications that occur if somebody were to get a trabeculectomy or a tube shunt. They're very long. It's a long list, and it's scary. And I wouldn't want a trabeculectomy or tube shunt in my eye unless I absolutely needed it. These are very high-risk surgeries, and many surgeons used to just allow glaucoma to slowly get worse because they were too scared to intervene with major surgeries. The angle-based surgery, again, why has the utilization increased? Safety. Us doctors now go, well, I can intervene without blinding somebody. And that's the beauty of a trabeculotomy or the Omni surgical system or the goniotomies. These are safe. We can finally do something that won't necessarily blind someone like a tube or trab, but you still get good data. I mean, look at the Romeo trial, 73% success rate. The GATT trabeculotomy study, 9 millimeters of pressure reduction. These are all fantastic results. And, 73% effect means now 73% less patients need to go on and get a trabeculectomy or a tube shunt. So I just want to paint the picture that these are things that help our patients. Removing these devices or this option would remove an effective and safe treatment that has been used for many years for thousands of eyes and with various types of glaucoma. I think it would increase the burden of eye drops for patients. We won't jump into tubes or trabs. We'll just say use more medications, which will cause more monthly expenditures, more costs to Medicare, more costs to the patient, increased ocular discomfort, ultimately more progression based on studies. And lastly, which I think is the major problem, is it increased ocular morbidity. Because now instead of at least trying an OMNI procedure or a goniotomy standalone, I'm going to have to go to a tube shunt or trabeculectomy. And if they have a serious complication, that's a disservice to that patient because they could have been treated and controlled, whether it was for 2 years or 5 years or 10 years, with a much safer option such as a trabeculotomy. And that pretty much wraps it up. I just want to urge CMS and all of you that are on the board to please reevaluate the data. The data is there. This is not something that's kind of voodoo and we're trying this out investigationally. This is something that the data speaks loudly, that surgeons are very passionate about, and to please update the draft policy to allow access to angle-based MIGS procedures such as the OMNI device, both with cataract surgery or with standalone. Thank you for your time and consideration.
Thank you, Dr. Yagurov, and thanks to all of the presenters. 3 very good presentations, a lot of information. We appreciate it. That ends the scheduled presentations for this meeting. We do have a few minutes left here for comments. Just keep in mind that preferred method of commenting is in writing so that we can respond to those in the response to comment articles. But I will open the floor in case anyone wants to make a comment.
Can you hear me? This is Dr. Jeff Welsh. I'm a practicing pathologist in South Carolina. I wanted to comment on the LCD regarding histochemical and immunohistochemical stains, if that's possible.
Yes, Dr. Welch, go ahead.
Thank you very much. I greatly appreciate the opportunity to just briefly make a comment about this. I'm a CAC rep. I've been a practicing pathologist now starting my 30th year in South Carolina. This is an issue that is of great concern to our members. And I just wanted to make the quick comment that the College of American Pathologists has submitted in writing, per your request, some specific changes we would like to have you look at in regard to the Ki-67 and prostate immunohistochemistry in particular. And I think they wanted me to comment on that because I have a very busy practice here of breast and prostate pathology. And I would just like to make the comment that our oncologists, our clinicians, our oncologic surgeons really have demanded that we include the Ki-67 in our reporting of breast cancer. So we have, and even without the compensation for that from Medicare since the recent LCD, we have to do that, and we are a big referral center. So when we get cases in, we've had to order that, and we're going to do that for our patients. They use that now in proper grading, risk stratification, and therapeutic options for the patients, and we have to present that data. So we would love the reconsideration of that from the MAC, and appreciate the opportunity to comment on that. The other brief thing I'd comment on prostate biopsies, the exact same situation where the exact number of positive biopsies now is being used by our urologists to make those decisions. They're made quickly, and I'd like to stress that these are a one-time chance to get these right when these patients start on their journeys of breast care, prostate care, etc. And the limitations we've had on some of these immunostains have affected clinical practice. We know why they were put in place. They were put in place due to some abusive ordering of stains, and nobody has supported proper ordering and proper use of stains more than the College of American Pathologists. And we just would love for you to look at those comments and let you know we are available to expand on that from a scientific or policy standpoint. And thank you greatly for the opportunity to have them relooked at. It's exciting for us. And thank you for for your time.
Thank you, Dr. Welsh. Yeah, appreciate that. And right, any other comments? And I should have made the statement. This could be for any of our proposed policies. So, any other comments?
Yes, this is Dr. Snyder, Matthew Snyder from North Carolina. I want to echo Dr. Welsh's comments as a representative from North Carolina, as a pathologist and member of the North Carolina Society of Pathologists, representative of the CAC, and on the executive board. I echo all of Dr. Welsh's comments, and I also completely support all of the points made by the CAP. As was mentioned, they were submitted in writing. We cannot agree with them more. I think they represent the accuracy of what we encounter every day on behalf of our patients. We understand the concern for overutilization. We share that concern in North Carolina Society of Pathologists and for all of the CAP, as Dr. Welsh mentioned. So we fully understand and support that, and don't want to see the pendulum swing in the other direction where it causes harm, which it could if the proposals are accepted as written. So we implore the CMS and the MAC to heed the CAP points, and we're also available in North Carolina to discuss further. Thank you all.
Thank you. Anyone else?
This is Nadia Nomova. I'm a pathologist in West Virginia, Charleston Area Medical Center on behalf of West Virginia Association of Pathology. I also want to voice my support for the points CAP made in proposed LCDs. I am oncologic pathologist with focus in breast, GI, and GU, and all these points hit hard. We prospectively use Ki-67 in breast cancer patients to stratify treatment. I'm a breast cancer patient as well, so I know firsthand the anxiety and trepidation involved with receiving results and getting on the right treatment plan, depending on all these immunostains and additional molecular testing. On behalf of our very busy GU practice and very impacted population here in West Virginia, thanks to the chemical plants that were here before, treating prostate cancer is not one fits all, and we also understand overutilization, but in multiple occasions, we need to stratify the patients and help our GU surgeons and oncologists to be able to choose the right treatment. And lastly, there was also another one for gastrointestinal pathology and Lynch and H. pylori testing. We have to use MMR testing not only for determining Lynch or absence of it. Nowadays, this testing is utilized to direct treatment again, and not only in colon and endometrial cancer, but also in upper GI, gastric, and nowadays small bowel tumors. So I really support the comments of CAP as written, and hope they'll be taken into account.
Thank you for that. We have time probably for one more comment if anyone wants to make one.
This is Matthew Freeze. I'm in Georgia, and I'll be brief. I just wanted to say I agree with the comments of my pathology colleagues, and I've read the CAP comments that they've either sent to you or are going to be sending to you, and I agree with those.
Thank you. All right. Anyone else? We have about 2 minutes left here. Okay. Well, hearing nothing more. Good meeting. Very good. We appreciate everyone that joined us today. Again, I've said it before, this is a very important part of the LCD process for us to have these discussions, receive these comments and presentations. So again, thanks to the presenters and thanks to all of you for being on the call today. With that said, we will conclude today's open meeting for Jurisdiction J. and wish everyone a very pleasant afternoon. Thank you.